Rex, good afternoon. We're waiting for Dr. Pippin. Rex, you're on.
Hello, Dr. Finn. Good afternoon.
Good afternoon. No, I started the meeting and then I got up to see a patient. I'm in clinic this week, so sorry about that if you're trying to reach me. But we're waiting on Dr. Pippin. He should be coming on shortly.
Okay.
And he'll be doing the delta gap and the different metabolic acidosis, etc., associated with it. So
Okay.
Let me touch base with him again. Rex, would you guys like to have the neurocritical care lectures, like the management of strokes and things like that?
Yeah, I think that would serve us well as well.
Okay. Because I'm sure you do get consults with neurosurgery, right? From internal medicine.
Yes, we do sometimes.
Okay. So I think I can get, they're not neurocritical care guys, but they're neurologists, and they always co-manage with critical care anyway. So I'll see how, because Dr. Pippin is not going to be available for next week and the week after, because he was supposed to do the safety issues in the ICU. Yeah. So I would have to reschedule that, and I'll see if I can do a neuro series next week for however long it will take to cover those series. Okay. All righty. Let me touch base with Pippin. I'll be back.
All right. Thank you.
Rex, were you able to share the presentation, the PowerPoint presentation with your colleagues?
Yes, I did. I did so, Dr.
Awesome.
Finn.
So you guys, just to give feedback, and I guess I should do some form of survey and get feedback from you guys because we want to do what works for you. You know what I mean? How do you think the lectures are so far? I'm still waiting on Pipim to join, so maybe we can just have a mini discussion on that. And I want to hear from the others. Is Rex the only one that we should know? We should know everybody else.
So, Dr. Finn, maybe you can, ask based on the names that are there.
I know. How about Enoch? Enoch, you came on very early. What do you think? Is Enoch a resident, a medical officer? Enoch Abe. Or anybody else? I mean, so far, what do you think? Do you want more lectures in a particular area? I know we've done a little bit of renal, we've done some cardiology. Cardiology, there's one particular lecturer who does some really great lectures on EKG basics. The problem is the timing. His Thursdays are always his, I think it's his cath day, so he's never able to do that. But maybe one of these days I might be able to get him on his vacation time and get him to do this talk. He really gives a good talk. He has actually written an EKG book and all that. But any other topics that you might be interested in? Neurology, I'm going to work on it. How about GI? Do you think there'll be a benefit to GI?
Dr. Finn, Nanajwa is asking, what the question is about.
Yes. Any feedback from the lectures? Are there any particular topics that you guys would like us to do? Any areas that you would want us to do more of? What do you guys think? Is Nanajwa unmuted?
Sorry. Good evening.
Good evening.
Sorry. We are in theater, so we are trying to pay attention as well as work at the same time. Apologies for that. So thank you for addressing the question. I think I've joined for the ABGs and they were super helpful.
Awesome.
Yeah, and I think we had one on kidney disease, if my memory serves me right, and it was equally helpful.
Awesome.
I'm not sure if we've had a lot on cardiac-based or cardiology-based lectures.
Okay.
I'm not sure we've had a lot. I would really appreciate if we could have more on a few lectures also as well on cardiology.
Okay.
Yeah.
Okay. I think we can work on that. We did do some arrhythmias and things like that with Dr. Obey from Ohio.
Yes, I remember that as well.
Yes.
But
we can get
more
cardiology. I think that's reasonable. We can get in more cardiology lectures. I'll find more lectures for that. And I think Dr. Pipim is on, so I'm going to. And I see YFO, Dr. Foley, you're on.
And please, if I may come in again. Yes. I'm not sure we've done apart from ABG, as in the respiratory aspect, we've not done a lot on respiratory pathologies and the way forward.
Okay, like respiratory failure, right?
Yes, respiratory failure and ICU management and the kind of stuff we see and all. Yeah, that would be really good. Thank you so much.
That's up Dr. Pipim's alley big time. So he will be back in 3 weeks and we will definitely get more lectures in that area. But we had done some vents, mechanical ventilation and all that initially. But we'll keep
you very much.
Thank you for your feedback. Are you anesthesia or your internal medicine?
Please, I'm anesthesia.
Okay, say hello to Audrey. Audrey was
my I will.
Okay then.
That's
Dr.
Nice.
Pipim.
She's in a meeting, so
okay, send her my love.
All right, so hello everyone. And hello, senior YFO. Good to have you on, and welcome to everyone. Sincere apologies for the 15-minute delay. I had to wrap up some things before this talk, and hopefully I will do a better job at scheduling in the future. But what I wanted us to go over was the last aspect of blood gases that we talked about. I still don't have any disclosures. And what we had done in the previous session was we talked about the 4 P's approach, where we look at the pH, we try and determine the primary process from the trend in the pH. We then see if the primary process is appropriately compensated for, and if it is not, that may suggest a second process. And then the third and final step, which is what we're going to try and review today, is there a third disorder? And the way we get to that is by initially calculating the anion gap. And then once we calculate the anion gap, we determine if one of 2 processes is present, if the relationship between the anion gap and the bicarbonate is not a 1-to-1 relationship. And we're going to go over specific examples and 3 methods that we can use to try and highlight whether or not there is a third disorder just by looking at the arterial blood gases. Can you all see my screen?
Yes, we can.
Jennifer?
Yes.
I'm not
Yep.
Jennifer. Penny.
Yeah, I can see it.
Okay, all right. Okay. So this just a quick review. What we did in the previous session was first look at the pH, determine if the pH is a true normal, which is 7.4. If it's trending alkalemic, it means it's more than 7.4. So 7.42, for example. If it's acidemic, it's 7.38, 7.35. Some will consider that in the normal range, but like we discussed, the purpose of breaking it down this way is to help us determine what the primary process is, just by looking at a true normal pH or slight changes in pH, either less than or greater than 7.4. We also looked at mixed disorders, which you can tell immediately. Once you look at a pH that looks normal and either a PCO2 or a bicarb that is abnormal, that immediately should tell you that you have a mixed disorder. We looked at the primary disorders, and this is just quick review. If PCO2 is high and pH is low, then that would suggest the respiratory acidosis and so on. And then we went over the rules of compensation. If it's an acute acidosis, for every 10 increase in your PCO2, there's a 1 increase in your bicarb. Similarly, for every 10 increase in your PCO2, there is a 3 increase in your bicarb for a chronic respiratory acidosis. And I taught you the +15 rule, which is for metabolic acidosis, you just have to add 15 to the bicarbonate in order to estimate what the PCO2 change should be. So for instance, if somebody has a bicarbonate of 10, the PCO2 you will expect with that bicarbonate of 10 will be 10 plus 15, or a PCO2 of 25. So if your PCO2 is, say, 30, that would suggest that you have a superimposed respiratory acidosis. If your PCO2, instead of being 25, is 15, you have a superimposed respiratory alkalosis. And for metabolic alkalosis, all you need to do is shave a 10th of the bicarb and add 50. So what we're going to focus on today is the third process. And the third process should only be proceeded with if you have an increase in your anion gap. If your anion gap is normal, you stop at step 3. Okay, so this is only applicable to increase in the anion gap, because we want to determine if the increase in the anion gap is accompanied by 2 other processes, one of two other processes, which would be a non-anion gap metabolic acidosis or a metabolic alkalosis if the change in both your anion gap and your bicarbonate does not fall within what is considered a normal range. So we'll go over some of the methods that have been used, and I think the subsequent slides should help us do that. This is one example, and we're going to use the delta, which is the change in anion gap from normal divided by the change in bicarb from normal. The range of normal is typically between 1 and 1.6. Some will say 0.8 to 1.6. I think the easiest thing to remember is look for a range of normal between 1 and 2, meaning the change in anion gap divided by the change in bicarbonate from normal should be in the range of 1 to 2. If you think about it, the reason why it is approximately 1 is that for every mole of acid added, meaning for every change in the anion gap from normal, you expect your bicarbonate to be titrated down by 1 mole. So it's a 1-to-1 relationship, but there are other explanations for why it is not absolutely 1 that are beyond the scope of this discussion. So suffice it to say, if the range is between 1 and 2, that is deemed to be normal. So Rex, as we always do, we will start with you. If you can help us calculate the anion gap here. Is Rex there?
Yes, Dr. Pippin. Please,
Oh, okay.
the question, my line dropped, so the question, please.
Oh, the question is, what is the anion gap based on these electrolytes that you see here?
Oh, okay, okay. So the anion gap is 34.
Okay, all right. So I also did the calculation, and it looks like we both agree that the anion gap is 34. And so the question was, is there an anion gap acidosis? And I think everybody on the line will agree that yes, there is an anion gap acidosis. So then the issue becomes, is this a pure anion gap acidosis only, or do we have more than just an anion gap acidosis? And the two other possibilities are an anion gap acidosis with a non-anion gap acidosis, or an anion gap acidosis with a metabolic alkalosis. So we can have more than one metabolic disorder once we identify an anion gap acidosis. And so what we're doing here is taking steps to then kind of determine if one of three things is going on. Is this a pure anion gap acidosis with no additional acid-base disorders? Or do we have both an anion gap and a non-anion gap acidosis? Or do we have an anion gap acidosis and a metabolic acidosis, alkalosis? So those are the three possibilities when we get to the final step, once we determine there's an anion gap acidosis. Any questions to this point? Is everything clear, at least to this point? Rex, I'm getting my okay from you.
Yes, there's nothing in the chat either, so I guess they're
Okay,
good.
all right. Okay, so then we have to come up with a method of helping us identify if we think there is an additional disorder on top of the anion gap acidosis. And one way to do that is to calculate what we call the delta. It just means the delta anion gap, which is the anion gap minus 12, which is the normal anion gap, divided by 24, which is the normal bicarbonate, minus the patient's bicarbonate. We expect that if the anion gap goes up by 10, the bicarbonate should go down by 10. So if we have an anion gap of 22, meaning a 10 increase in anion gap, then we expect our bicarbonate to drop from 24 to 14, which would be a 10 decrease. And that would suggest that the only problem that we have is an anion gap metabolic acidosis. However, if we do our calculation, all right, and we're doing our calculation here, bicarb has changed by 10. So meaning our normal bicarb is 24, our current bicarb is 14. So there's been a 10 change in base. And so Rex, can you pick on one of your team members to tell me what we would expect the anion gap to be if our bicarb changed by 10? If this was just an anion gap acidosis.
Nana Joy, you want to try? Nana Joy is anesthesia.
Boss, please, to be honest, I've not been paying attention. I was just gonna go offline when I heard my name.
I got you.
The place is a bit busy. I'm so sorry. Please
You're
forgive
fine.
me.
You're
I'm
fine.
sorry. Please. I'm sorry.
Any volunteer? Dennis?
So Mount can try. Yeah, I can also try.
So what would we expect the change in anion gap to be if the bicarbonate change was 10? What value would the anion gap actually have, knowing the normal anion gap of 12? What would the anion gap that we will calculate be if this was just an anion gap acidosis? Anyone? And you know I'm waiting to give you an excellent if you give me the correct answer. So just to speed up things so we can get through it, we would expect that if the bicarbonate changes by 10, then the anion gap will increase by 10. And if a normal anion gap is 12, then we would expect that the anion gap that we calculate will be at least 22. So that's the point of this step where we've calculated our anion gap and it's 34 instead of the 22 that we expect based on how much the bicarbonate has gone down from normal. So the only way we can explain, and let's do this. So our anion gap change was 22. Our bicarbonate change was 10 from normal. Okay. So the only way we can explain why our anion gap increased by 22 from normal, but our bicarbonate only decreased by 10 is that we must have had excess alkali to begin with that allowed us to drop from that high level to an eventual level of 14 because we had excess alkali to help neutralize the increased acid that we had. So to do the calculation and to predict what we think the bicarbonate was before the anion gap acidosis occurred. We can predict that just based on knowing how much the anion gap changed by. So anion gap changed by 22, bicarb changed from normal by only 10. And so we can predict that the initial anion gap was probably 12 higher than normal, given the difference between these two, 12 higher than normal, and therefore the initial bicarbonate was probably in the range of 36. And if you subtract 22 from 36, you end up with 14, which is what the bicarb was when you drew your blood gas. In other words, your excess bicarb was represented by a value of 36. You added 22 moles of acid, and after you added 22 moles of acid, you ended up with a bicarb of 14, which is the bicarb that you measured in your blood gas. However, when you compare the change from normal, it will be less than the change from normal with the anion gap acidosis. And I know I've said a lot, and these concepts are not always as straightforward and as easy to understand. And so let me pause here for any questions. And don't be shy. My goal is to try and help you understand these concepts.
Hello, Dr. Pippen. If you don't mind, if I may interject here.
Okay.
I'm sorry I tried to join in, but I'm actually on the road and
oh, sorry about
I've
that.
been in and out, but I think I just got back in right at the time you were talking about the Delta.
Okay.
If Rex and the rest who were present at my presentation, was it last week, couple of weeks ago? If you recollect, I did say at that point, and Rex agreed with me, that dealing with the Delta is a very confusing concept.
Yes, yes.
And I try to simplify this process to them by drawing an analogy to ghosts.
Okay.
And I told them that situations where we have elevated anion gap metabolic acidosis should be thought of as a situation where we have some ghost anions enter the patient's system or blood. We call them ghosts because we're not measuring them. Things like lactic acid, formaldehyde, and stuff like that are usually not measured on the chemistry profile. And that is what is making the anion gap seem to be depressed. That's what is making the total anions of chloride and bicarb seem to be depressed and hence elevating the gap. So by that, I told them that the anion gap could be looked at in terms of some ghost anions in the system that we are not measuring. And going on from there, we said, if you have a delta, which is greater than 1, then you think that you have a lot of ghost anions around, but they are not causing as much acidosis as you expect them to do. Because normally, as you said, each ghost anion must depress the bicarb level by 1. It's a 1-to-1 ratio. But here, if we have a lot of ghost anions around, and yet they're not producing that much acidosis, then you think of them as weakened ghosts, so to speak, wimpy ghosts. And what is making them wimpy or weak is that there must be some other counterbalancing factor in the system, which will be an alkalosis, right?
Yes.
So what you are talking about right now is the mathematical illustration of that explanation I tried to give them last time. Rex, if you recollect, I believe working through this together with what we discussed last time should help kind of make it less confusing. I won't say simplify because it's never simple, but this is exactly what Dr. Pippin is addressing right now.
Yes, so no, thank you very much, Dr. Waifo. And thank you very much for trying to simplify the concepts. This, I think, is, as Dr. Waifo said, is the more difficult concept or difficult way of trying to determine additional acid-base disturbances. And I have two other methods that are used. The second method is mainly used in Europe, but the third method is one that I learned from one of my, I guess, instructors in fellowship, that I think, for me, is the simplest concept. And so I want you to incorporate everything that you just heard from Dr. Waifo, and also you learn to use other methods to try and better understand this. But the key thing here is applying it and making sure you can explain why differences exist and how those differences exist in a way that will make sense to you. So the delta, I will say, is principally focused on is the change in your anion gap matching the change in your bicarb if both started from a normal level. And if your change in anion gap, let's use another example, because that is typically simpler. If your change in anion gap was 10, but your change in bicarb was 20, there, I think most people will agree if anion gap only changed by 10 and bicarb changed by 20, there has to be a second source of acid that is causing the bicarb to change by 20 instead of the 10 change that you expect if it was only coming from an anion gap acidosis. And so the only possible explanation will be there are two sources of acid, one an anion gap acidosis that changes by, say, 10, but there has to be a non-anion gap acidosis that changes by another 10 if the total change in your bicarbonate was a total of 20. So I think that if you think about non-anion gap acidosis and how it impacts your delta, you expect a small numerator, which is your anion gap, and a bigger denominator, which is your change in bicarb, and that numerator over denominator will be less than 1. I think that that concept is a little easier to understand. However, when you are looking at change in anion gap, okay, it changes by 10, but bicarb only changes by 2 from normal. You have to ask yourself, how did I neutralize the 10 moles of acid? Okay, that change in anion gap. And the only way you can technically do that is if you started with alkali levels that were higher than normal and were titrated down below the normal, but not much of the change resulted in the higher than normal bicarbonate that you had. So I think the simple way of restating what I just said is if your delta is less than 1, there is a non-anion gap acidosis. If it is greater than 2, there is a metabolic alkalosis. But let's not dwell too much on this method because it's not the only one. There is something else called the delta gap. And we're using the same example to go over what we call the delta gap. So the delta gap is actually the change in your anion gap minus, so not divided by, but minus the change in your bicarbonate. You will expect that if there is no other acid-base disturbance, that gap, that difference, should be equal to 0. But as with all of these equations, there is a range. And the range for the difference between the delta gap and the delta bicarbonate is plus or minus 5. So how is that calculated? Your delta gap is equal to the change in your bicarbonate subtracted from the change in anion gap. If you think about it again, if the change in anion gap is, say, 10, but the change in bicarbonate is 20, that would suggest that there is a second source of acids. And so when change in anion gap minus change in bicarbonate is a negative number, that would suggest that you have excess acid or a non-anion gap acidosis. And if the change in anion gap minus the change in bicarbonate is a positive number greater than plus 5, it suggests that you have excess alkali. Remember, the changes that we're talking about are from normal, not from the actual values. All right. So in this example, the change in bicarbonate is 24 minus 14. The bicarbonate is 14. The normal bicarbonate is 24. So that gives us a change in bicarbonate of 10. The change in anion gap is still going to be 34 minus 12, which is the change in anion gap from normal. So now the delta anion gap minus the delta bicarbonate, which is your delta gap, is going to be 22 minus 10, which gives you a positive number. And like I said, the normal range is going to be plus or minus 5. If it's greater than positive 5, that's a metabolic alkalosis. If it is less than minus 5, then it is a non-anion gap metabolic acidosis. So using a different formula, subtracting the changes in anion gap and the changes in bicarbonate, you can arrive at the same answer. If it's positive, it's a metabolic alkalosis. If it's negative, then it is a non-gap acidosis. But that too can be very confusing. So my all-time favorite, which is what I want you to walk away with. I just taught you these two things just because you may see them on exams and you may need to figure out a way or more than one way to determine if there is an additional acid-base disorder. But the one that I like the most and the one that I teach my residents now and the one that I think they assimilate the easiest is something called the initial bicarbonate. So essentially what I'm trying to show here is where did my patient's bicarbonate start from before the anion gap acidosis occurred? If the bicarbonate is within the normal range, the true normal range, then that is consistent with just an anion gap acidosis. If the bicarbonate was initially high, that is going to be consistent with a metabolic alkalosis. And if the bicarbonate was initially low, below 20, then that points to a second source of acid titrating down my bicarbonate lower than I expect for the normal range. So let's try and apply that here. So again, is there a normal anion gap acidosis? Yes. What is the initial or starting bicarbonate? So how do we get to that number? We typically should add what our current bicarbonate is to the change in anion gap, because that will tell us this is where our bicarbonate is right now. What was our bicarbonate before the anion gap acidosis occurred? Okay, and we can figure out what that bicarbonate was, because we know there's a one-to-one relationship between increase in anion gap and decrease in bicarbonate. So if my bicarbonate is here now, let's say 14, and the change in anion gap was 10, then I can say with confidence my bicarbonate actually started from 24, 10 moles of acid were added, and I ended up with a current bicarbonate of 14 after the 10 moles of acid were added. And if your initial bicarbonate is in the normal range between 20 and 28, there is no additional acid-base disorder. If your initial bicarbonate started high, it's say 36, that's a metabolic alkalosis. If it is less than 20, that's a non-anion gap metabolic acidosis. Let me pause here for questions. Any questions? And like I said, please don't be shy. Let's work through this example, okay? So change in anion gap is 34 minus 12. Same value we've gotten in all those other calculations. Now we want to determine what is our initial bicarbonate. And the way we do that is our current bicarbonate is 14, okay? Change in anion gap is 22. So our bicarbonate actually started from a value of 36, which is already consistent with a metabolic alkalosis. So we used different methods, a delta, where we divided the anion gap by the change in anion gap by the change in bicarbonate, and we said less than 1 non-gap acidosis, more than 2 metabolic alkalosis. We also used a delta gap, which is just change in anion gap minus the change in bicarbonate. If it's a positive number, metabolic alkalosis, positive more than 5. If it's a negative number, non-anion gap acidosis. And then the final thing we did is this initial bicarbonate. What did my bicarbonate start at? Did it start high? That's a metabolic alkalosis. Did it start low? That's a non-gap acidosis. Did it start normally? That's a normal, that's only an anion gap acidosis.
Dr. Pipim, can you give examples?
Yes.
Of clinical scenarios?
Yes. Okay. And I may have just done the same thing. This is not the example. We have all this. Yeah, I didn't have time to review the slides, as well as I want us to go through. Okay, so here is a blood gas, and I'm just going to walk you through this particular blood gas. All right. So you have this pH, you have this bicarbonate, and just going through our previous steps, pH is acidemic, the bicarb is low, and so this is a metabolic acidosis. And if we calculate the anion gap here is 23, which is 127 minus 104. And so that gives us an anion gap of 23. A change in our anion gap is going to be 23 minus 12 or 11. Okay, so it is an anion gap metabolic acidosis. Now, what we want to do is determine if it's just a pure anion gap metabolic acidosis, or we have a non-gap acidosis, or we have a metabolic alkalosis on top of the anion gap metabolic acidosis. So here, I didn't have time to use all three methods. The first compensatory or process number one is the adequate compensation. Here it's straightforward. Bicarb plus 15 should give you an expected PCO2 of 20. This patient's PCO2 is, however, 10. So this patient is hyperventilating, blowing off CO2. And so just from the compensatory formula, we can determine that there is an anion gap acidosis from the anion gap and a respiratory alkalosis. Because there's an anion gap acidosis, now we have to determine, is there a non-gap acidosis or is there a metabolic alkalosis? And here I think I used the delta, okay? So delta anion gap, the gap is 23, normal gap is 12, and that gives us a delta gap of 11. Our bicarbonate changed from 24 to a bicarbonate of 5. So the change in bicarbonate is 19 compared to the change in anion gap of 11. So it means that if this was just an anion gap acidosis, if our anion gap increased by 11, we should expect our bicarb to decrease by 11. However, our bicarb, instead of decreasing by 11, actually has decreased by 19. That doesn't happen by chance. That happens because we have a second source of acid that is causing our bicarb to decrease by more than the 11 that we would expect if this was a pure anion gap metabolic acidosis. And so that ratio is certainly less than 1. It's almost 0.5. And that tells us that in addition to our anion gap acidosis, there's a second source of acid that is causing our bicarbonate to drop lower than we expect if this was just an anion gap acidosis. Questions? So the thing that I would say about this is, if I changed the bicarb, okay? If I changed the bicarb to 13, all right? The change in anion gap will be 11. The change in bicarb will be 11. And this same equation will suggest that this is just an anion gap metabolic acidosis, because the change in anion gap matches the change in bicarbonate. Similarly, instead of 11, if I said the bicarb was 20, okay, change in anion gap will still be 11, but now change in bicarb will be 4, meaning I must have had excess alkali present that caused me to be able to neutralize the 11 moles of acid, but only change the normal bicarb by a small number, meaning there was excess alkali present that allowed me to neutralize those 11 moles of acid. So when the change in bicarb from normal is small, there's excess alkali. When the change in bicarb is great, there is excess acid.
Dr. Pepe, what clinical scenario can present like this?
Certainly. So someone who comes in with salicylate overdose, okay, who is vomiting, all right, can present with triple acid-base disorders. So salicylates, okay, induce a respiratory alkalosis because of tachypnea. They also generate a metabolic acidosis because of lactate production. And the vomiting, because of loss of hydrochloric acid and secondary hyperaldosteronism, can develop a metabolic alkalosis. So aspirin overdose with vomiting, but regular run-of-the-mill sepsis, okay, septic shock, tachypnea is one of the things that can develop early in sepsis. Shock leads to a metabolic metabolic acidosis. And if these individuals are vomiting or have some gastroenteritis as the cause of their sepsis, then they can develop a metabolic alkalosis. So there are lots of scenarios that can present typically due to kind of a primary disorder that is complicated by certain additional disorders.
Another fairly common scenario too would be DKA with vomiting.
Yes.
That's a fairly common scenario.
Yes.
That you see DKA people that are vomiting, you are very likely to get into this kind of situation. And
no, thank you very much for
back. If we go back to last week or the other week, this is what we were saying.
Yes.
This is the reverse situation of the one we discussed earlier, where you have a situation of relatively few ghosts in the system, few ghost anions, but those few ghosts are causing too much acidosis for their numbers. So this is the one that I refer to as you have macho ghosts in the system. What is making them macho? What is making them seem much stronger than their numbers would suggest? Like Ukraine versus Russia, right? So you are saying, how is Ukraine able to withstand Russia, right? And you're saying because Ukraine is getting assistance from another acid-producing situation, which is now a normal anion gap metabolic acidosis, which is the USA and the Western countries sending weapons to Ukraine. So they are able to fight against, the bigger numbers of Russia. That's what is happening. So these are some of the scenarios that can produce this sort of picture. Yeah.
Yeah.
Thank you.
I completely agree. I think DKA is definitely one of the things that you see fairly commonly in Ghana. And the patients who have DKA typically are tachypnic, and so they develop a respiratory alkalosis. Obviously, when they are volume depleted, they can develop a metabolic acidosis, but again, because they don't have enough insulin, all right, they generate keto acids that can cause a metabolic acidosis. So there's respiratory alkalosis, there's metabolic acidosis, and if they're vomiting, they can have a metabolic alkalosis and present with numbers that represent that what you see in this particular example here. I mean, in this example, it's a non-gap acidosis, but they could have renal tubular acidosis, or they could have even diarrhea that will give you a non-anion gap metabolic acidosis. So these are certainly possible. We just have to break it down into, okay, what's the pH? What's the primary process that is causing the pH? Is it appropriately compensated? And if not, is there a second process? And then the third and final step is, what's my anion gap? And is my anion gap equal to my change in bicarbonate? If you go through those 4 steps consistently, you will be able to recognize every single acid-base disturbance that is present in your patient. And the next step is, as Dr. Finn mentioned, trying to figure out an explanation for why those things are occurring so you can correct it appropriately. I know we're just past the hour, but I will hang around for another few minutes to see if you guys have any questions. And please don't be shy. I mean, these concepts I didn't learn in one sitting. And I still am trying to look for ways to make it easier for people to understand. So by asking questions, you may actually give me the opportunity to create something as creative as my senior Dr. Waifo has created with his ghosts. I may come up with something else, or maybe use his ghost. Any questions?
Dr. Pippin,
Yes.
I know you are off for next week and the week afterwards.
Yes.
But one of the residents, I believe from anesthesia,
Okay.
Or if we could have some form of like Q&A. So
like definitely. Definitely. I will be happy to do any, I mean, if they have patient scenarios that they want to discuss, happy to do that too as well.
Okay, yeah. So I've asked them if we could get case presentations from their end as well. That could generate more discussions. Definitely. So we'll talk afterwards and see when we can do this and schedule this.
Okay, sounds good.
Yeah. But we'll have to do the ICU safety before we.
Okay. Definitely. Definitely. I mean, I think that those are things that we don't always think about, but we should, because I mean, those are interventions which, if we use consistently, we may be able to avoid some of those complications that are associated with just being in the ICU that have nothing to do with the underlying disease. The underlying disease is difficult enough to treat, and so we need to minimize any kind of complications from things like stress ulcers, DVTs, catheter-associated infections, just nutrition-related issues. All of those are encapsulated in a mnemonic called FAST HAGS BID. And so I think that every ICU caregiver should be aware of those things and obviously apply them to their patients as they care for them in the ICU setting. So happy to do that too as well.
Rex, any other questions? And I'll send out this PowerPoint to you guys as well as soon as Dr. Pepem shares it with me. And Waifo, if you could send your nephrology PowerPoint.
No questions, please. I think this session has actually explained further the Delta we're talking about the other day.
Yeah.
Thank you very much, Doctor.
You are most welcome. And please, 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 don't be shy about reaching out to Dr. Finn. And you can reach out to me too as well. And I can continue the discussion to help kind of clarify things, because when you start applying it, you realize, oh, I don't remember what he said here. Or why does this have to be done this way? And so just give yourself as many opportunities to keep reviewing it and getting to a more complete understanding of this. So we'll see you in about 2 weeks or 3 weeks, and we'll continue from there.
Yeah, but we will have another session next week. So I'll keep you guys posted. And I will try and get out the critical lecture series to anesthesia has been asking of it. So Dr. Share that one, I'll edit it and then we can take it from there.
Okay, sounds good.
Thank you.
Right. Good luck to everyone, and very nice to see you, my senior Waifo.
Yes.
Thank you very, very much again.
Take care. Bye-bye.